welcome Dr. Mohammad from Kuala Lumpur.
Okay, Assalamualaikum and good afternoon to everyone. First of all, I would like to thank Paulo, Lydia, and the World Federation Neuro Rehab for getting me here alive and safe despite my mishap. This paper, we hatched it. That's my husband, Michael O'Leary, and Khairul couldn't be here. He's my IT manager in Hospital Rehab Cheras. How many of you have heard of Hospital Rehab Cheras? Well, we kept Anwar Ibrahim for 7 months in that hospital. So the title is Challenges in Providing Tele-education in Augmentative and Alternative Communication in Developing Country, and the developing country is Malaysia. How many of you have been to Kuala Lumpur? Oh my God, all of you have to come to Kuala Lumpur. We have the tallest twin tower in the world, right? The other one was bombed, right? So this is the content. AAC is a subspecialty in speech and language therapy. So in Malaysia, we have about 200 speech therapists in the government setting and about 300 in the private setting. To get access is very difficult. They charge 100 ringgit. That would be about 20 euros per hour. And that's actually steep for the general public. Very difficult access. So we need to use a transdisciplinary approach. So in Malaysia, speech, language, and SLT is rare. So occupational therapist will be the next person to do AAC. All right. So the aim is to see whether it's possible or not to teach non-allied, non-SLTs on the concept of AAC in a developing country. It's a prospective study from August to September, about 3 months last year. And this was proposed by my husband. He was looking at our hospital. It's a very grand hospital. You must come. Yeah, that's our hospital. That's my husband. And he said, would you like me to teach your staff? So I'm like, what do you want to teach? Anything. So in my culture, it's called jual mahal, like play hard to get. Yeah, that's the word. So I was like, oh, you want to teach? All right. So I went like, okay, what topic would be appealing that we don't know much in Malaysia? So it would be AAC. So yeah. So I lost 1,000 euros, last night. So it's the cost of flying my husband from Queensland and back to KL. So I thought, okay, so if we can get my husband to teach AAC via tele-education, why not? Okay, saves us the flight, carbon footprint, and time. So this is where I work. And we had to prepare. We didn't know what we were up for. So the bulk of the exercise is to see what are the components that we had to do, whether it's feasible or not. So to prepare is the main stumbling block. To set up, we had the IT people. Otherwise, I'm technophobe, so I had to have a lot of support from our technical staff, and then deliver it and to get some feedback. So the first few sessions were conducted in our IT center, training center, and it was conducted via Skype. Just made an announcement to the hospital, okay, whoever wants to come and listen to these talks, please come. So the bulk would be the nurses, and AAC is something that they feel that would be useful for them in the wards, like activities of daily living. How do you communicate with patients who cannot communicate after a stroke or brain injury. So a lot of times when we speak about AAC, they don't understand what is AAC, doctor. So we always have to, or the speech therapist, so we always have to explain what is AAC, augmentative alternative communication. And we had to use a number of channels. The biggest one that was helpful was my unstolen phone. DG is the network, and WhatsApp. I use WhatsApp a lot. Last year I presented on just the contents of my team's chatters in the WhatsApp group. We tried using Skype. It was quite frustrating because we found out that that's my IT manager. We found out that it's choppy. Yeah? We can't get a straight go for any session. And I had to learn all these gadgets. I didn't know what a microphone should look like, or how do you actually use the adapters, all that. So it was more like a teaching a technophobe how to use technology. It was feasible. And then the outcome measure that we used was a questionnaire by Parmanto. I translated it into Malay and simplified it. It's not a Likert scale 1 to 5, but I simplified it, yes or no. And then the feedback was, where's the column for I don't know? So I was like, okay, so if we were to do any feedback, you should have a column I don't know, because you can only say yes or no if you know what is the topic that is being taught or discussed. So these are the results. The contents. Okay, so we planned for 10 sessions, but in reality we could only do 6. And these are the topics that my husband, Michael, has lined up. Assuming nobody knows about augmentative alternative communication. So the content of the lectures were mainly targeted for non-SLT audience. In my hospital, we also have a simple dynamo box AAC, and that's my speech therapist having some face-to-face synchronous dialogue with the presenter. We also found out that the YouTube videos showing the contents of the AAC, when the videos are playing, you can't really hear the presenter's voice. So it's either or. So to save that frustration, we just put links, and then in their own time, they can watch the videos, the YouTube videos later. Okay, so the methods that we used were asynchronous, which is store and forward, and also synchronous. Okay, the asynchronous, so the preparation bit of the tele-education required a lot of emailing, WhatsApping, and also printing material, because I think the nurses are so used to conventional ways of learning. They have to have notes, they have to write. So anything that is just verbal or visual is not enough for them. So I had to, Michael had to email his notes first, and then his slides first. I had to print it out and then distribute it beforehand, so they knew what was going to be taught in the subsequent lectures. So this is a comparison between synchronous and asynchronous. So we found out that after 6 trials, we had to use 5 out of 6 a shared hotspot, my reliable phone, because we found out that our hospital network, it's okay to Skype each other within Malaysia, but once it leaves the borders, it doesn't work. So I had to email my superiors in the Ministry of Health and revamp the telehealth policy to make it like it's not just, you don't just unbar the widthband and the access to a certain period. It should be just free for all. The problem is the Ministry of Health do not want us to play Facebook during work. So that's why they cap it. So I had to justify why I want an unrestricted, unlimited access to overseas. And yeah, this is the problem. The capacity was only 20 megabytes per second, shared by 800 hospital staff at any one point, and reaches over 90%. So most times 100% at a time. And then we could only have 20 minutes uninterrupted, and then we have to redial. And then when Michael's talking, I have to WhatsApp him, no, we can hear you, just get on, because the other side might think that you can't hear him, but you still need to have the backup to give feedback. No, just continue. So the last button, the internet usage recorded by the bandwidth is between 2 to 5 megabits per second, depending on the volume of content. So videos, YouTube videos, big pictures, a lot of will take a lot of space and time. So you need to see how feasible it is to cram everything within the capacity of your hospital or center. So these are the organizations that we had to liaise with. TM is our national telecommunication network. It is very useless, and we have to make do with whatever we have. And funding, Ministry of Finance, as you all may know, Malaysia, we're not poor, but just goes to one person. Yeah. All right. So personal smartphone. Yep. This is a 4G Wi-Fi smartphone, iPhone. Very reliable. So you can use this to educate any parts of the world in Malaysia. Special request is I've done that. All right. So this is just comparing challenges and how to circumvent the challenges. So you combine. I'm always somebody who wants to see, okay, where's the loophole? So if there's no policy, attack it. You see, policy makers, they try to make it so regulated that you are not supposed to think out of the box. So the way my brain works is I always look at the loopholes. So I'm not breaching any policies because they don't exist, the way I think or the way I do things. But you use the gap. You use the gap and get your objectives achieved. What else? Okay. So the feedback we got from our participants, this I think it's a very easy to use. And Parmanto, I wrote to Parmanto, apparently he's the supervisor of the speech therapist in my hospital who has a master in AAC. How lucky is that? Small world. So I wrote to Parmanto. He's actually Indonesian, but based in Philadelphia. He said, yeah, sure, just translate it to Malay and then you can use it. So I divided the domains into usefulness, ease of use, effectiveness, reliability, and satisfaction. And more than 90% of our participants reported positive feedback on the ones in red. Yeah, so they said that telehealth or teleeducation saves time and cost. It is also a way to deliver healthcare and increases access to health and education. The advantages, it increases access, distance, you don't have to travel. And we also tried, so instead of everybody comes to the IT room, we tried the wards. So we also tested our connectivity between one part of the hospital with another. So that was also a steep learning curve for our IT people, and use that as an opportunity for improvement, because everybody wants ISO status. Okay, we didn't do so well in the reliability and effectiveness, because that's not what is beyond our control. Okay, so we had to tell our bosses to increase the bandwidth and the restriction, lift the restrictions. So the ones that rated lowly, it says that I can see the presenter clearly. So a lot of them didn't agree with that. And then I can express my feelings, or whatever I'm feeling, to the presenter. So they found that that's not really effective in tele-education. And this system can do whatever it wants. No, this system does whatever I want it to do. So that's something that they didn't rate highly. So we took their feedback seriously and improved on them to the level that we could. And so mainly they were happy with the usefulness and effectiveness. So in summary, tele-education increases access to expertise in health and education, saves cost and time. It's a steep learning curve for every single part and component of the exercise itself. And we told our bosses what we wanted, and we got it. The conclusion is you can use tele-education just with your smartphone, and don't have to rely on your hospital network in wherever you are. So it is useful for a developing country as well as a developed, I think, and carries many challenges. So the recommendations that we made to our bosses, the policymakers, is to amend the existing OneGov.net telehealth policies and create a special interest group in telehealth among stakeholders. In our WhatsApp group, all the rehab physicians are in the Malaysian Association of Rehab Physicians, MARP, and I am the person to push telehealth in every single niche. So some people like community-based rehab, some people like brain injury. So I always promote whatever you do, make sure there's a tele in whatever you are doing. So this is my email. My phone number is not there. Okay, the number is +60112 678 6362. Thank you. Any questions?
Thank you. Thank you very much. You've been completely in time. So we have a few minutes for discussion if you have a question for her.
Thank you for the very nice, interesting presentation. And I had just a curiosity, so it's a chance to talk about your country, your environment. I was just curious if traveling in the Western countries, is a chance for you to get some new inputs to bring back home and to improve this kind of approach to education. So which kind of new inputs come to you from this kind of chance?
Okay, it starts with marrying the right man, from the right country, from the right discipline. No offense to physios, but OTs are, they make better husbands. Sorry, Tom. Yeah, I take your point, yes, I agree. I did my MBBS in University Malaya, in Malaysia, and my master in rehabilitation medicine in the same institution. But as part of our training, we get to spend 6 months abroad, or not only abroad, wherever you want. So I told somebody today that I wanted to be a neurosurgeon and have friends everywhere. So at the time, my senior from boarding school, she was doing her fellowship in Cardiff.
Mhm.
So as a medical student, I went like, okay, can I stay with you like for a month? And I went to the University of Wales, Cardiff, and saw a lot of brain injury cases, MPTP, ice ecstasy, young people on ecstasy having Parkinsonism, and all that. So having this, going to other countries, and then I live in Australia as well. You get to see the world. There's a Malay saying, jauh perjalanan, luas pemandangan. It means the further you travel, the wider your horizon.
Yeah.
Very wise, my ancestors. And when you have the knowledge, skills, and the right attitude, it doesn't mean that you can just copy and paste whatever you learned in your setting, okay? Because there are 3 types of people in this world. It's a pyramid. Only 1 to 3% are visionary. The next tier, about 30% are processors, and 70 to 90% are actually just operator, like a factory. So you tell them, they do. If you don't tell them, they don't do, or they only do one thing. So you have to find a balance between whatever you learn from one country, and this is a very good forum where I think the theme is different countries, different needs, different ways, but it's the same needs actually, same. Everybody wants a good quality of life, easy, you don't want to travel, you want cheap, so you got to think out of the box and use whatever resources that you have. And the simplest, maybe sometimes it's something that it's just in front of you, but you didn't think of it. So I saw in Facebook, apparently, there's also tele-witchery by the Romanians. Did you know that? If somebody has put a spell on you, you can get your traditional medicine person to dispel the curse via WhatsApp or FaceTime. Yeah.
Thank you very much.
Okay.